The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome again, TMD warriors. We are gathered here for the next episode of TMD Demystified, and I am Tony Urbanek. Today, I am going to try to answer for you the question, why TMD is a progressive disease. Well, let's first define the term progressive, if it's not obvious. The symptoms associated with TMD, the damage associated with TMD of various kinds, goes from incipient to larger and greater and more frequent, then to life-changing, then to the point at times where this disease is limiting the enjoyment of life. I have honestly never encountered anyone who has died of TMD. As I've mentioned before, I have three documented patients who have told me that they considered suicide because the pain was unrelenting. They had seen enough practitioners who could not give them relief. And then one of these particular people I have on video making that statement in sincerity. It seems sincere to me. Certainly she was not seeking praise or interest from others. She was just being honest. But I have not seen anybody die of TMD, but I have seen many lives ruined. And we have actually salvaged many of those people. And that is why I can smile so greatly about this problem. But why is TMD a progressive disease? Because it does go from bad to worse. And it is progressive in the number of symptoms. So it's not only, in the degree of pain, but it's progressive in the symptom sequence that occurs in this problem. And, most of the people that watch these episodes, I am sure, do not have the familiarity that I have. I'm sure that some of them are somewhat familiar. There may be someone who's more familiar, but, my knowledge about this, as I've stated, really has been developed since the inception of the Urbanek device and protocol, and understanding actually why this problem comes into being, which is inflammation within the temporomandibular joint. Inflammation creates and drives all of the symptoms, emphasis on all. But the disease itself is progressive in the sequence of symptoms that occur, and is progressive in the degree of pain, discomfort, and debilitating aspects in life, which includes how the patients describe the problems. So, patients will describe the beginning of their symptoms, and invariably they'll talk in one way or another about how over a period of time things get worse. And that's probably the first way. There are many ways to describe progressive. That's what I'm trying to say. You can define progressive in multiple ways. And so we're going to try to, in the next 25 minutes, take each of those descriptions of progressive and try to make it real to you, what to expect, what to see, what to look for when you're doing an interview, a consultation, with a person who supposedly has TMD, because in a consultation, as in anything that you do in your professional career, I mean, first you get a history, then you do an exam. If you have some lab or x-ray studies that need to be done to confirm or give you more information, then that's done. And then you take all that information, put it through the computer, and hopefully we'll come up with a successful diagnosis, and then have at hand and at ready a treatment plan that will be equally successful as your successful diagnosis. That's the state of medical science, including dentistry and all of medicine. So TMD is a progressive disease, and basically let's describe why it's progressive in those certain aspects. So first of all, it's progressive in symptoms. In that 5,000 plus consultations I've done, the patients, for the most part, of course, there are outliers. Everything's on a bell curve, and there are outliers on the bell curve, but I'll be talking about the majority of the standard deviations under the bell curve. The majority of people start out describing this problem either starting with no symptoms and just noises from the joint, clicking, click, 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 or headaches. And you can have TMD without noises for sure. You can have TMD with noises. You can have headaches with or without noises, but those are the two, usually the two starting points, start out with headaches or noises. Now, there are exceptions. As soon as I say that, somebody's going to throw at me, well, I had a patient. Of course you did, I'm talking about, most of the bell curve and how these histories come about. So, but as far as starting out with a noise, it's the click, 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 which indicates nothing more, nothing less than a loose meniscus. The cartilage itself is loose. I call it, in front of the patients, I describe it as a cushion. It's good enough description for a patient. And the cushion gets loose. The meniscus starts to get loose. Why does the meniscus start to get loose at the beginning of this? Because inflammation drives the whole process. And as inflammation takes over to some degree or another the internal structures within the temporomandibular joint, ligaments that hold the meniscus in place get loose, and it starts to click. So you have the ball, the socket, and the cushion, and in a healthy joint, it's supposed to move a little bit and silently. You don't have TMD in infants. Have you ever heard an infant, a 1 or 2 year old, have a noisy joint? No, you don't, because they have not had enough. They don't have, first of all, they don't have any teeth. Secondly, hopefully they have not had any trauma. And the meniscus itself, which certainly is in there anatomically, but it hasn't had time to get beat up and to become one way or another inflamed within the joint itself. And just to repeat myself, the damages within the temporomandibular joint have only 3 causes: bruxism, functional malocclusion, and various kinds of trauma. And that's what creates your inflammation. And, in a youngster, and of course, I've heard of multiple kids in their 6 years, 7 years, 8 years old category who actually have noises clicking from the temporomandibular joint. And those are almost for sure, unless it's a severe anatomical damage to trauma, due to trauma, would be a functional malocclusion of one kind or another, or possibly severe bruxism, because definitely 5 and 6 year olds can brux. If you do much of this, you're going to have a lot of moms come in and say, my God, my 5-year-old makes a whole lot of noise with their teeth at night. So the first step on the progression is noisy joint. And then at one point or another, usually the first actual symptom, because noise is a sign, the first symptom shows up, and the most likely symptom to show up will usually be the headache. The second most common symptom in adults is neck pain. But once the joint becomes noisy and the inflammation takes hold, headache is first in sequence, but you can have described as earaches. You can have it described as jaw pain. You can have patients point directly to the ear and say it hurts, but that will be the first indicator that the patient has some symptoms. Now, why is it limited to the head usually at the beginning? And that's because inflammation creates a sequence of events which communicates with the brainstem and says we are inflamed here in the temporomandibular joint. Temporomandibular joint is inflamed, and the brainstem and the nuclei within the brainstem send back an autonomic signal to say tighten up. And the first signals to tighten up the muscles of mastication. So the muscles of mastication get tight, and wherever the attachments of the muscles of mastications are, and it pulls on the periosteum and stimulates the nociceptors, and it will create pain of various kinds, of various degrees, at various times, under various circumstances, and it can be all over the head and the neck, wherever the muscles of mastication are. And so that's the first portion of the progress of the symptoms. Then when the inflammation is not resolved one way or another, then whether it takes a month or it takes 20 years, the information is then signaled back from the information from the joint, signals the temporomandibular joint inflammation to the brainstem, and the brainstem says, now, we tightened up the jaw muscles, the muscles of mastication. Now I want you to tighten up the neck and the shoulder girdle. And that's when patients will complain of upper back and shoulder pain or tightness that can actually transfer all the way into the pectoralis muscles and the trapezius. And patients will actually point to the areas where those muscles are attached. The most common one that I have seen is the attachment of the trapezius or the sternocleidomastoid at the mastoid process, trapezius across the back of the cranium, and literally point to where the muscles are attached, in conjunction with some of the primary muscles. And they move around and go around at times, but it progresses from muscles of mastication down into the neck, down into the shoulders, and then eventually can cause arm, hand, finger tingling, numbness, because the strap muscles on the side of the neck can squeeze the brachial plexus, and patients will complain of arm, hand, finger tingling and numbness and pain. So it's progressive in the degree or the route that this problem takes. It's also progressive for what I term the middle symptoms, which is the tinnitus, subjective hearing loss, and vertigo. Because what I have seen over those years and 5,000 patients is in both males and females, but more prominently in males, can't tell you why, but it is more prominent in males, they will more likely be complaining of tinnitus, subjective hearing loss, and vertigo. And you will not hear as many complaints from the males about, although there are exceptions, many exceptions, they won't complain as much about the pain around the head and neck. And you'll see many males come in with those middle symptoms. I play them in the middle because the sequence is headache, earache, jaw pain, neck pain, ringing, fullness, dizziness, shoulder pain, arm, hand, finger tingling, and numbness as it sequences down. But the tinnitus, subjective hearing loss, and vertigo is related to inflammation getting access to the middle ear, where the mechanisms, the vestibular mechanism and your hearing mechanism is located, which will translate into those three symptoms at different times, under different circumstances. But again, it's all driven by inflammation. So it's driven anatomically from head to neck to shoulder to arm, and it is driven to the degree and amount of inflammation that is in the joint and how long it has gone unnoticed or untreated. Inflammation isn't an all or none. Inflammation is progressive as time goes on, and certainly as the stimulus for the inflammation is not removed but may increase, then the damage is more likely to the material or tissues within the temporomandibular joint, especially the meniscus. So first it gets loose, and then over a period of time, the influence of the inflammation on the meniscus and the lining of the glenoid fossa, but particularly the meniscus, because it is unprotected. It is totally cartilaginous. Blood supply is none. It is supplied through the synovial fluid. Its nutriments are supplied through the synovial fluid. And so as the inflammation within the joint gets worse and the breakdown of the synovial fluid itself and mechanical mechanisms of chronic bruxism, functional malocclusion, or acute trauma influence also the health of the meniscus, the inflammation gets worse and worse and worse, which again creates those sympathetic signals to the brainstem that says, hey, we're inflamed in here, we need some help. And so it's progressive over time, depending on how rapidly the inflammation can increase in quantity and quality. And of course, that is dependent on outside influences of bruxism, subjective bruxism, and functional malocclusion and acute trauma. So now what are the countermeasures that I've run across regarding the progression of this disease? The first is the patient's personality. And again, that's why it is best if you're, and I encourage you to treat TMD, obviously, but those of you who wish to do this, I encourage you to learn to sit and listen to your patient, at least for a while. Now, some patients can go on for half an hour, and you really can't do that all the time, but you learn so much from your patients. And when you do and sit and listen to the patients, you will learn that their personalities have a lot to do with how long they can put up with their symptoms. And some patients cannot deal with any of the symptoms, or at least for very long. And other patients, by their personality, which can be changed or differs between how they were raised or their socioeconomic level, all kind of factors that we don't need to get into now. But there are people who can tolerate a lot of pain. And actually here in Middle Tennessee, it's a beautiful place to live. I can usually tell when someone was born and they have this problem and they have severe symptoms, but you will not hear them complain. They'll describe the symptoms, but they'll describe them in a way that certainly isn't looking for sympathy. And I can, more often than not, those people have been raised in the rural areas. They were raised on the farm, they've been raised on horse farms, and they're tough people. They're just tough by nature. And I see it all the time. And then there are others who are not so tough. I'm not trying not to criticize or denigrate those personalities, but there are people that are not so tough, at which point you will hear a higher level of complaining about their symptoms, and they describe them quite differently also. But you can have the same level of symptoms and get quite a different description from the patient. Same level of symptoms, different description. So, and then secondly, there are patients who actually are pain tolerant, and that will have an influence on how much those symptoms, whatever they are, impinge on their life. And I cannot describe or try to tell you why some people are more pain tolerant physically. I'm talking physical pain tolerance, except for this one factor. I have noticed, this is just information, this is an informational episode, this is an informational podcast. And so for informational purposes, I can tell you that athletes, and I have my theory about that, but athletes are very pain tolerant. And I've seen that quite often, not only in working with TMD patients, but working through my career as a maxillofacial surgeon, both office kind of surgery, extractions, impactions, dental implants, but also in the operating room with patients with major reconstruction, necessity, trauma. Athletes are very pain tolerant, and it doesn't have to be a young athlete. It can be someone who had an athletic career, and they may not be as athletic as they used to be, but they can tolerate a whole lot more pain. Now, there may be other categories. It's the one I picked out because it became very obvious to me when I saw a reaction from whether it be an iatrogenic induction of pain or whether it be an outside influence of pain, same amount of pain, kind of same thing, and a group of patients who were just very tolerant, and very frequently they had a history of athletic accomplishment, athletic history. So it is progressive on the anatomy from head to neck to shoulder. It's progressive on the amount of inflammation which is within the joint, and it is progressive on the amount of damage within the temporomandibular joint. The progressive damage within the temporomandibular joint, I do not have a timeline. There is nothing wrote about my comments made today about progressiveness of TMD. But most definitely, the longer the inflammation is allowed to progress within the temporomandibular joint, the more damage is done to the structures within the temporomandibular joint. So there's also the definition of progressive nature of it is progressive damage within the joint itself to the meniscus, to the cartilaginous surfaces of the glenoid fossa, and the of course, we already commented, how loose the cartilage can be. Having the opportunity as a maxillofacial surgeon actually to open up, literally view the temporomandibular joint at least 1,000 times. I've done about 2,000 temporomandibular joint cases. Half of them have been open joint through an incision, periauricular incision in front of the ear, access to the entire joint itself, and half of them through an arthroscope. Of course, you're limited in your ability to see within the arthroscope. Much easier to actually see and evaluate the structures within the temporomandibular joint with the eyeball. And so many of these jaw joint problems with a 20, 30-year history, you open up the joint, and the meniscus itself is not only dislocated, but is damaged to the point where, well, it has a perforation in it. The most common view I've seen is it just looks like a soft, mushy little piece of pancake that really has no anatomical structure to it. It's just a beat up piece of tissue. And that is one of the reasons why, trying to do surgery, I finally gave up on trying to do surgery, reconstructive surgery on temporomandibular joints, because by the time they got to see the surgeon, the tissues were so badly damaged, there really wasn't much to do. And we've commented on the fallacy of trying to recapture a disc either surgically, because once it's out of position, you're not going to pull it back with sutures. It's not going to happen. At least stay there. You can pull it back. It's not going to stay there. And of course, non-surgically with the multiple kinds of devices, intraoral orthotics, to pull the mandible forward and recapture the disc. Well, by the time they have symptoms, that disc is so beat up, there's really nothing to recapture. So getting back to the point, TMD is a progressive disease in many aspects, depending on how you define progressive. So it's progressive in anatomy as it goes from head further down. It's progressive in the amount of pain. and symptoms, and it's progressive in the amount of damage within the joint over time. Now, how rapidly does this all occur? It really varies, and it varies according to the amount and degree of damage which is done through those three types of damaging incidents. And those are hard to control. Of course, a traumatic incident is usually a one-time deal. Although I've talked to people who had, for one reason or another, abusive histories, or they were I've treated several boxers who ended up with progressive damage to the joint due to trauma. But the events themselves cannot be exactly described at times. You don't know how long and how much someone bruxes to cause damage within the joint. Some people can do a little bit of bruxing and cause a lot of damage. Some people can do a lot of bruxing and not do a lot of damage. It is really hard to describe. It has so much to do with the forces of the muscles that are placed and the length of time that bruxing goes on. So many types of changes that can go on. It's impossible to put a rote description on how long it takes for these progressive events to occur. So unless someone else wants to try to quantify it, I have not. I don't see the point in doing that. But for those who treat TMD, get it out of your mind that you're treating a problem that just came up all of a sudden. Because if you have symptoms for TMD, I saw one yesterday. Again, today is Tuesday when I do these episodes, when I record these. Saw a patient yesterday who claimed that his symptoms, as a man, his symptoms only began occurring 6 months prior. Looking at his x-rays, just the Panorex x-ray, I could tell that he had to have at least 20, if not 30 years or longer of terrible inflammation within the joint, because he already had subchondral cysts within the glenoid fossa. So for those of you not familiar with the subchondral cyst, I don't want to leave you hanging. The subchondral cyst is an iconic description of inflammation influences where the bone within the condyle itself, before the condyle will collapse, the cyst itself will get hollowed out, and you can see them on a Panorex. You don't have to get an MRI or CT scan. And I've stated before, you hardly ever, if ever, have to get a MRI or CT scan to properly diagnose TMD. It's kind of used. You can get a lot more information. No, I didn't say you can't get more information. What I said is to diagnose it. You're getting a lot of extra information that you don't need to spend a lot of money on to get, because you can make a very adequate diagnosis without an MRI or CT scan on TMD. All right, so it brings up the final question. If and it is, we've tried to describe why TMD is a progressive disease, then the question that comes from that, or the question that should come from that, is, when do you treat it? And that's a good question. When do you treat it? And I think that it's a question for discussion. It's a question that should be discussed with the patient. I don't think there's any ultimate one answer. I think a case can be made. Because we know one fact. If you unload the temporomandibular joint long enough, consistently enough, the inflammation will decrease, diminish, die down. Just like a set of crutches will take the load off a knee, which allows the inflammation within the knee to decrease, diminish, and die down, which will decrease the symptoms of a knee problem. Now, you may not want to walk on a set of crutches your entire life, and that is why you don't see that happening. But it is much easier, much easier to use a device that separates the back teeth and only the anterior 6 touch consistently according to a protocol that unloads 90% of the loads within the temporomandibular joint, allowing the inflammation to die down, decrease, which allows the inflammation, allows the symptoms to go away. It's much easier to use one of these, both at the beginning, 24/7 for a while, according to the protocol, and then go to nighttime. It's very easy. So you can literally quote, if you will, use a set of TMJ crutches or crutch, 2 joints, 1 device, a TMJ crutch to unload the joint adequately to allow the inflammation not to interfere and damage the internal structures, create the symptoms over a period of time. So with that said, and the simplicity of treatment, then the question is, well, it's this pretty simple treatment. When do you start? Well, first of all, to use a device like this, you have to have a complete set of teeth. You can't treat young children who have mixed dentition. First of all, teeth are growing so fast. They're coming in within a few weeks. They're changing constantly over time. And so until they at least get out of the mixed dentition stage, you can't consider treating them with the Urbanek device. I don't recommend it. I don't do it. I don't see how it could possibly be effective functionally over time. But after that, once you get out of the mixed dentition, then you can treat pretty much from that point, early adolescence, all the way into aged patients. So when to treat? Well, you can make a case for treating when they get their first symptoms. Frequently, I see patients who come in with just noise. They come in, and I ask them, do you have any of these other symptoms? Do you have frequent or recurring headaches, earaches, jaw pain, neck pain, etc.? And the answers are no, 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 no. I'm just, it's making all this noise and it's driving me crazy. I don't like the noise. Is there anything that I can do about this? Well, the answer is yes, possibly, by unloading the joint. And if they understand that that's all you're trying to do and that's the end product of decrease the noise, then I cannot say that would not be an appropriate treatment. But more often than not, what I say to the patient is, noise is a sign, not a symptom. It's not a good sign. But if that's all you're dealing with is the sign and the noise, come back and see me when you have some symptoms, which will usually start out as a jaw pain or a neck pain or a headache. At which point, then, it's time. When they have symptoms, even one symptom, then it's time to treat. Sometimes patients will come in with maybe just 1 or 2 or 3 symptoms, but they're really minimal symptoms. They go, well, I have a headache, once a month, and it hurts occasionally when I chew my Cheerios too hard. Then it's up to the patient. My response to that is, well, how much do these symptoms really bother you? Because you have the choice. We can treat you, and the symptoms will diminish. That is a given. Or you can just deal with it until the symptoms get out of hand, at which you can come back. So the answer about when to treat this progressive problem is primarily, what I'm trying to describe is up to the patient, not the doctor. Now, you can make recommendations. I would recommend, like I do, to describe what to expect. I definitely describe that it is a progressive disease, which it is. 100% of the time, it progresses. Now, sometimes the progression is straight up. I mean, it's like a straight up line. And sometimes it progresses at an uneven rate. And sometimes the patients will describe symptoms that go along, kind of increasing slightly, and then boom, all of a sudden it'll shoot to the moon. All of those could be defined as progressive symptoms, a little differently, but they're all progressive. So really it's up to the patient to decide when to treat under the recommendation, or let's just say under the direction and instruction of the doctor describing is what to expect. And actually, when most patients know that is a progressive disease, and that is really what tripped my interest in doing this episode, is the patients and the doctors need to know it's a progressive disease. The doctors need to know how to describe the progression of symptoms to the patient adequately, accurately. with enough certainty that this is a progressive disease, and to the patient so that they understand it's a progressive disease and what they can expect. And then between doctor and patient, you can decide, with the ultimate authority being the patient, when to treat and when to put them in a device that will unload the joint and most certainly decrease the symptoms and get them on the path to health regarding temporary in the joint. All right, I made my point. I hope I've made it succinctly enough. Hope I didn't drone on too much. I definitely appreciate your attention at all times. I encourage comments. I encourage criticisms if you'd like to. I'm always available to talk with you at tony@tmjservices.net. If you'd like to join our network of an increasing number of doctors who use the device for the betterment of their patients and their practice, you can get more information from Naomi at tmjservices.net, or you can look up our website at tmjservices.net and get more information, and be happy to help you understand a little bit more. There's so much information on the other episodes of the podcast on Dental Town. I encourage you to look through those and find topics that you find interesting. So for today, we'll wrap it up. I am Tony Urbanek, and I look forward to speaking with you next time. This is TMD Demystified.